morning everyone. I'll be presenting an unusual case of macular hole in a young male. Normally when we talk about macular holes, we usually suspect them to be idiopathic, so they'll be more commonly seen in the 6th and 7th decades. Whereas when we talk about the younger age groups, the most common cause usually is trauma. So this case was a sliding move over.
Slide.
Okay, so this was a 30-year-old male who was the first issue of a non-consanguineous marriage who presented with gradually progressive diminution of vision for the past 1 year in his left eye. Unfortunately, he had history of trauma to his right eye 8 years back with a firecracker injury, and in his past history, he had a history of night blindness and was using high-powered glasses for the past 15 years. His systemic and family a corneal scar extending from the 12 to the 5 o'clock position. A USD B scan was done. It was suggestive of a disorganized globe structure, suggestive of phthisis bulbi. In the left eye, his vision was finger counting close to face with intraocular pressures within normal limits. His anterior segment was within normal limits, whereas on a dilated fundus examination, we could see areas of chorioretinal atrophy in the periphery with scalloped margins and a posterior pole retinal detachment combined with a macular hole and a fixed retinal fold in the inferotemporal quadrant. We went ahead and inquired about the glasses that he was using. So it was minus 22 diopter sphere in his left eye, and his axial length for that eye was 30.91 in the presence of a posterior pole retinal detachment. So this is the image that was there. You can see the red circles highlight the areas of chorioretinal atrophy with the scalloping of the margins almost involving the posterior pole and there's presence of a full thickness macula of a macular hole. A diagnosis of gyrate atrophy with high attachment associated with macular hole was made. We went ahead and did serum ornithine levels, which was 824 micromoles per liter. Normal values are moles per liter. We did an ERG. There was an extinguished response in the ERG. Now we were in a dilemma. ERG extinguished response could be due to the gyrate atrophy as well as due to retinal detachment. We discussed this with the patient, and because he was one-eyed or monocular, we went ahead and offered a 25 gauge pars plana vitrectomy with ILM peeling with inverted ILM flap, which was done under explained visual prognosis. We did a 25 gauge pars plana vitrectomy, following a core vitrectomy, a triamcinolone acetonide assisted posterior vitreous detachment was done. It was extended to the periphery as much as possible. Then an ILM staining was done with BVG 0.05%, followed by release of the membranes at the posterior pole. At this point, iatrogenic breaks were formed because the membrane was tightly adherent. No problem. Myopic patient, we removed the PFCL, went ahead with membrane peeling as well as ILM peeling and an inverted ILM flap. We went ahead and did a fluid air exchange, and at this point we utilized the iatrogenic break as a posterior retinotomy, and an endolaser was applied to the break. Following which, standard post-operative treatment was advised, including an arginine-restricted diet and vitamin B6 supplementation that is most commonly done for gyrate atrophy. On post-operative day 7, we had used an intraocular tamponade with SF6, so you can see 50% filled with gas and multiple sections of the OCT showing that the hole had closed. However, there was poor gain of visual acuity. So we know that gyrate atrophy is autosomal recessive, caused due to mutation in the OAT gene, which causes accumulation of ornithine, which is a toxic byproduct. Causes of macular hole in this patient, we went ahead and did a literature review. We found out that there are multiple macular involvements that have been reported in the past, but there is only a single case in which a full thickness macular hole has been reported. However, ours was different in terms of having a longer axial length, having a posterior pole retinal detachment associated with it, as well as a good anatomical outcome, even if the functional outcome was not great. So in our case, we dealt with a triple dilemma of myopia associated with a macular hole and a posterior pole retinal detachment in the setting of gyrate atrophy. 25 gauge vitrectomy helps, but early diagnosis is key so that arginine restricted diet is instituted at the earliest. Thank you.
Thank you, Nawazish. I think it was very good. I think one point in this was where do you drain. So I think that you already answered because
Yes,
that retinotomy happened, because that is one very important
Yes,
aspect
sir.
of this. The other thing that I wanted to comment was that with a 30th axial length in these eyes, I would have probably preferred 23 gauge.
Yes, sir.
Not that 25 does do reach, but the important take back message is that sometimes there's a staphyloma over there,
Yes, sir.
especially at that point where the macular hole is. And when the staphyloma will never be picked up on a B scan, on an axial length scan
Yes, sir.
at times because it's little juxtafoveal something. So I think 23 gauge was the only thing that
Yes,
I
sir.
probably elucidated.
Because of the flexibility of the instruments with 25 gauge.
Yeah.
Yes, sir.
So otherwise, I think very well managed and very well done.
Thank you so much.
If it shows the examination and the diagnosis, if it was diagnosed earlier, could we have prevented macular hole?
So usually macular holes, so the causes of macular holes could be due to...
Gyrate atrophy,
Sir,
if you would have detected earlier, could we save the vision
Actually no,
with
sir.
arginine
Because
therapy?
actually no, sir. Arginine therapy would not help in that. Arginine therapy would only help in reducing the ornithine levels and further damage. Whatever RP loss and everything that has happened before we initiated that would not be able to be reversed.
I think the cause for the macular hole is more of abnormal vitreous cases.
Yes,
So
sir.
they have multilayer vitreous cases
Yes, sir.
in these cases, and that causes the macular
Yes,
holes.
sir. The anterior posterior traction combined with the vitreous.
digestion. So that really would not.
Earlier, how many cases of gyrate atrophy you have seen?
So we've seen a few at RP center, but
Few.
with macular
Ideally,
hole,
we
I've
were
never
not
seen
able
one.
to diagnose these cases. We were not. This is one of the interesting cases where she was able to diagnose gyrate atrophy and very good presentation. Okay, thank you.
Thank you.